All right, well, let's go ahead and get started. Thank you all so very much for joining us here today. My name is David Griffith. I'm the Director of Programs and Outreach for the LGBT Elder Initiative at the William Way Community Center. For those of you who are new to Doctors in Programs, this is a partnership between us at the Elder Initiative and Jefferson Health, specifically the Jefferson Center for Urban Health and the Jefferson Department of Family and Community Medicine, which includes the geriatrics division. So each month we have different Jefferson doctors coming to present on different health topics. We've been doing this actually almost 3 years now, and we've covered a lot of great health topics and are continuing to do so. And so today we're going to be talking about heart health. Before we get into today's presentation, I wanted to introduce Dr. Liz Spina, who some of you may recognize from past Doctors in Programs, but who is doing a new project around LGBT health and wanted to share some resources with folks today. So I'm going to turn it over to Liz just to speak for a couple minutes before we get started.
Thank you, David. I just wanted to thank you guys for giving me a little moment of your time. And I wanted to tell you about this initiative that we started at Thomas Jefferson Center for Healthy Aging. We noticed that historically the medical community hasn't been the most inclusive, and our practice of non-malevolence hasn't been perfect, particularly to LGBT older adults. And so we really wanted to improve the care that we deliver, not just in terms of comprehensive care, but also inclusive care. And so we began this initiative to really work on our ability to deliver comprehensive and inclusive care to older adults that identify as LGBT at our community clinic. And we began our initiative by first self-reflecting on looking at our own comfortability in delivering care. And so the first part of the initiative, we surveyed our staff, and that feedback was used to further practice enhancements and improve the training that we deliver to our staff at the Center for Healthy Aging. The next process, or the next step, is to really ensure that our idea of inclusivity mirrors that of Philadelphia and the community that we serve. And so we would really love to hear from you guys. We've created a survey of about 10 questions that goes through different topics such as health concerns, life concerns, and values really on the medical community. And that feedback would be used to provide further practice enhancements and further training, and really help shape local medical services that we have at Jefferson. The hope is that we can create a model at the Center for Healthy Aging, and then that can be extended to more offices at Jefferson and really kind of make a large impact in the Philadelphia community. And so I really hope to hear from you all. I know David is going to send out the consent form in our chat. And within that consent form has a link to the survey. And so I really look forward to hearing from you guys and improving the care that we deliver to our older adults.
Awesome, thanks, Liz. And I just put, I think I actually maybe in the chat just put the link directly to the survey, but I will send out also the consent form that has more information. But thank you, Liz, for joining us. I can also email this out to folks after the program. So we appreciate any and all responses. And for folks on Facebook, I'll include this in the comments. So shifting into today's presentation, talking about heart health, we have a new Doctors in presenter with us today. So welcome to Molly. And just a couple of housekeeping things, which probably folks know from Zoom by now. You are welcome to and encouraged to put your questions and comments either in the chat or as a Q&A in the Q&A feature. So both of these options should be in the bottom toolbar of your Zoom screen. Just know when you are chatting, your name comes up with your comments. So if you are submitting anything that's more personal with your questions that you don't want your name attached to, you should instead do that through the Q&A feature. and there is an option to submit those questions anonymously. For folks with us on Facebook, just write your questions or in the comments field. I'll be checking those and I will relay those to today's presenter. Thank you again for joining us. I'm going to turn it over to Molly.
Hi, everyone. Thank you for having me today. Today, we're going to be talking about heart health, which is something that is so common and I'm sure personal to a lot of you or people that are in your life. And so feel free to not only write comments or questions in the chat, but to unmute yourself and ask questions and share whatever you'd like. This month is, American Heart Month. So it's a very relevant topic. And what we're going to do today, we're going to look at, we're going to learn about what the most common types of heart disease are, look at how it affects the general population, talk about some of the symptoms of heart disease, and focus quite a bit on how we can prevent it. And even if we already have it, think about how we can be healthier. And then if we have time at the end, we'll take a quiz together and test our knowledge. So what is heart disease? It's a broad term and it refers to a group of illnesses that affect the heart. And the most common of these is a condition called coronary artery disease. You'll sometimes see it called CAD. And there are a lot of other types of heart disease too, including heart attacks, heart failure, and arrhythmias, which is when the heart has an abnormal electrical rhythm. We will talk a little bit about heart attacks. We're not going to talk about heart failure or arrhythmias, but if you have questions about either of those, you can certainly feel free to ask. So this is a map here pointing out just how common heart disease is in the US. It's looking at all women older than 35 by county, and the darker red just shows where there's higher incidences of heart disease. And the CDC also has a map that looks at the rate of heart disease, particularly deaths, not just heart disease, in men over 35 by county, and it looks really similar. It's just that it's a little bit more prevalent or a little bit more common. And for both men and women, it's the leading cause of death in our country, and that comes out to being 1 in every 5 female deaths and 1 in every 4 male deaths. So what exactly is coronary artery disease? This here is the heart, and these little vessels that feed the heart are responsible for bringing blood and oxygen and nutrients. And if we were to cut through this artery right in the middle and look at it, it would look kind of like this top one. And this is a normal, healthy artery. It has a wide open space in the middle with plenty of space for red blood cells to move through it freely. And when you have coronary artery disease, there's a plaque, and we'll get into later what makes up this plaque, that starts to build along the wall of the vessel and starts to destroy the wall of the vessel, and it creates a much narrower space for blood to flow through. So you can imagine if it's much harder for the blood to go through this artery, it's going to be a lot more difficult for the heart to get the blood and the oxygen and the nutrients that it needs. And so just having abnormal vessels, that is when you're considered to have coronary artery disease. And so what causes this exactly? So it's this buildup of plaque that happens over time. And there's a lot of reasons that this happens, and we'll talk through some of those. And this is just a different way of looking at how when this plaque builds, it's a lot harder for blood to flow through nicely. And the process of this plaque accumulating along the wall of the arteries is something called atherosclerosis, which really just refers to the formation of this plaque along the vessel wall. And so what are the symptoms of this? The majority of people won't have any symptoms at all. If you have so much plaque buildup that it causes the arteries to narrow in a significant way, you might have some chest pain when there's not enough blood getting to the heart. And then a more extreme version of that is when there's no blood getting to certain portions of the heart, and the heart muscle itself is effectively dying, and that would be consistent with a heart attack. And oftentimes a heart attack will be a person's first symptoms of coronary artery disease at all. And so there are certain conditions that I'm sure you've heard a lot about at this point and are familiar with that can make it more likely for you to have heart disease or make you more susceptible to it. And that includes high blood pressure, having high cholesterol levels, diabetes, and obesity. We're not going to talk about diabetes and obesity today, but later on we will look more closely at high blood pressure and high cholesterol and how we can manage that a little bit. And so in addition to those health conditions, there are a lot of behaviors that can increase your risk of heart disease. So some of the non-behavioral things that we think of in terms of increasing your risk of heart disease include genetics and your family history, which you really don't have any control over. Your age, as you get older, your risk increases, and that also, of course, you don't have any control over. And some of these conditions like high blood pressure, diabetes, you can do things to help, but you can't always change them. But there are a few things on this chart that you can actively work toward changing. And those include your diet. An unhealthy diet makes you more susceptible to having heart disease. Not exercising can put you at higher risk, and smoking can significantly increase your risk of having heart disease. And then here in the middle is kind of some of the complications, the end result of long-standing untreated coronary artery disease. And so just because you already have coronary artery disease or a doctor has told you that you have heart disease, it doesn't mean that there's nothing that you can do to be healthier. And there's two main categories of things that you can talk with your doctor about and focus on to help be healthier, even if you already have heart disease. So the first category of things is lifestyle changes, which would refer to those behavioral modifications, specifically quitting smoking, adjusting your diet to focus more so on whole grains and vegetables and less so on salty foods and fatty foods, and getting more physical activity, which doesn't have to be anything crazy or going to the gym every day or anything like that. It can even just be walking for 20 minutes most days of the week. And then the other category of things that you can focus on to be healthier, even if you already have heart disease, is medications. And this is something that I would encourage you to talk with your doctor about to see if you need medication to treat your high blood pressure or high cholesterol, because treating those can help your heart disease. This is just a graphic from the CDC showing that just how common heart attacks are. They say they have found that every 40 seconds, someone in our country has a heart attack. So from there, we kind of looked at earlier how coronary artery disease forms. And a heart attack is basically just the more extreme version of that. So before those arteries that we saw, the normal ones were completely open without any plaque. With coronary artery disease, you had some plaque where it was harder for the blood to go through, but it was still going through. And when you have a heart attack, often it can be because the plaque is taking up all of the space in this vessel and no blood can get to the heart muscle. And this like more purple part of the heart is showing the muscle that has died because it hasn't been able to get any oxygen. And I think there are a lot of classic symptoms that people associate with heart attacks. And those are chest pain or severe pressure, discomfort, trouble breathing, pain in your chest that radiates to the jaw or your neck or back or arms or shoulders. And there are certain groups of people, especially women and especially people with diabetes, who can present differently, who might have those classic symptoms, but also could have a heart attack and their only symptoms are feeling nauseous or kind of faint or really fatigued. And it can be, in those patients, a little bit harder to diagnose. Not saying that if you feel those things, it means that you're having a heart attack, but just something to be aware of, that that the symptoms of a heart attack can look different in different people. And so in thinking about what things put you at higher risk for a heart attack, it's pretty much the same exact things that put you at high risk for coronary artery disease: diabetes, high blood pressure, high cholesterol, smoking, family history, age, an unhealthy diet, and not getting enough exercise. And as with coronary artery disease, even if you've already had a heart attack, there are still things that you can focus on to optimize your health afterwards. And it's the same things that we've already touched on. The three big things are more physical activity, healthier foods, and quitting smoking. And those aren't things that you have to suddenly do all at once, but that you can work over time just towards generally healthier habits. And so with both coronary artery disease and heart attacks, I talked a lot about how high blood pressure can put you at high risk of those things. So we're going to talk about what exactly blood pressure is, what it means to have high blood pressure, and how we can best manage it. So the blood pressure itself just refers to the pressure that the blood causes against the wall of the arteries. And when you get your blood pressure checked, you'll see a top number and a bottom number. That top number is called the systolic pressure. And this just refers to the pressure in your arteries when your heart beats. So as you're getting your blood pressure taken, you probably feel that pulsation in your arm. So with every pulsation, that's measuring the systolic blood pressure. And with every time you don't feel the pulsation, that little pause in between is measuring the diastolic pressure, which will give you that bottom number. And both of these numbers can be high for different reasons. So high blood pressure is when that pressure is a little bit too high. And most people have absolutely no symptoms when their blood pressure is high. If it's really, really acutely dangerously high, you might have things like chest pain and headache and dizziness, but more commonly, you don't have any symptoms at all. And that's especially true of people whose blood pressure is a little bit too high on a regular basis. And the reason this is so dangerous is because if the pressure is high, the blood just isn't going to as efficiently get to the heart or the brain or the kidneys, all of which are key organs. And when that pressure is really high over time, it can start to lead to damage. So in the heart, it can make you more at risk for a heart attack. With the kidneys consistently being faced with high blood pressure, it can eventually lead to chronic kidney disease or kidney failure. That's over a long, long period of time. And also having consistently high blood pressure can make you more at risk to have a stroke, which would affect the brain. So a lot of people want to know what their blood pressure should be. And it really kind of depends. A lot of different organizations and different governing bodies have different recommendations for what they think an ideal blood pressure should be. But for most adults older than 60, most of you will, your ideal blood pressure would be either less than 140/90 or less than 150/90. And which of these is better for you really depends on your own health status and what other medical conditions you have. And you can certainly feel empowered to ask your doctor about, based on your individual circumstances, what your blood pressure goal should be and how you can best achieve that. So I'm starting to get repetitive here, but it's a lot of the same things that you can focus on to manage high blood pressure. It's again about cutting back or quitting smoking, getting about 150 minutes of physical activity per week. And this comes out to like a little bit over 20 minutes per day of the week. Finding whatever ways work for you to best manage stress, making sure you're getting enough sleep. And then for a lot of people, even when you're doing a great job of all of these things, you still might have high blood pressure and you still might have to take one or more medications to keep your blood pressure within a safe range. So you're probably familiar with at least one place where you can check your blood pressure. I'm sure anytime you go to the doctor, your doctor will check your blood pressure, or you'll have it checked even before you see the doctor. You can always go to a pharmacy nearby, and they usually have an automatic cuff that you can sit next to and check your pressure. And you can even get a cuff at home. You can either buy one or your doctor can help prescribe you one so that you can measure and log your blood pressures at home if that's something that you and your doctor feel would be beneficial for you. And then this guy here is just demonstrating the optimal way to have your pressure taken. The main things being that you're really relaxed. You have your back straight against the back of the chair. Your feet are flat. You can take a few deep breaths before your pressure is taken. And your arms should be nice and relaxed and at the same height as your chest. And the cuff should be one that fits you well, because if it's too tight or too loose or put on over several layers of clothing, that can give you either a falsely low or a falsely high reading.
So one question, Molly, that came in is there a best time of day to check your blood pressure? And I'll add to that, should you be like tracking it at the same time every day?
That's a good question. I don't think there's really a best time of day, because it's really normal for your blood pressure to fluctuate throughout the day. And that's not concerning. As long as it's consistently within whatever range you and your doctor have decided is a good one for you, then that's okay. And I think for most people, you don't need to be checking your pressure every day. Maybe if you're really trying to get it under better control, maybe once or twice a week. But if it's going to give you more anxiety to be paying attention to the numbers and tracking it regularly, then you can just hold off on logging it at home and just have it checked when you go to your doctor's office.
And for those who would be monitoring at home, are those like at home blood pressure cuffs, are those pretty accurate? I know there are a lot of different ones on the market for that sort of thing.
It really depends. What I always tell people, if they have a cuff at home that they rely on, is to bring it to their next doctor's appointment so we can compare it to our cuff here and kind of calibrate it. Because some cuffs are really accurate, but some are not. And sometimes over time they can become a little bit less accurate. But there are a lot of manual cuffs that are really good.
Great, thanks.
And then the other risk factor that we kept talking about, in addition to high blood pressure, was high cholesterol. And I think there tends to be a lot of confusion about what cholesterol is and why there's good and bad cholesterol. And cholesterol itself is just this like waxy, fatty, yellow substance that our livers make. And it's an important substance that we need. We need it because it makes hormones in our body and it helps us digest fatty foods. And our bodies make all of the cholesterol that we need. As long as our livers are functioning, we're not at risk of having too little cholesterol. But the majority of people who have high cholesterol are getting too much cholesterol, not from their bodies, but from the foods that they eat that are high in what we typically think of as being bad cholesterol. So normally, LDL, which is low density lipoprotein, is considered to be bad cholesterol. And this is most of the cholesterol that's in our bodies. And the reason it's bad is because if you have too much of it, it can significantly increase your risk of heart disease and stroke. And if you have too much of this, that's when your doctor might start talking to you about taking a medicine to help lower your cholesterol. And there are a lot of medicines that can lower your cholesterol, but by far the most common one is a statin. And we'll talk a little bit more about statins in a couple slides. And then what we normally refer to as the good cholesterol is the HDL, which is called high density lipoprotein. And you have a lot less of this in your body, but it's considered good because it helps the cholesterol get back to your liver. And once it's back to your liver, the liver can kind of get rid of it from the body. And having high levels of good cholesterol can actually lower your risk of heart disease and stroke. And if you don't have high enough levels of good cholesterol, in that case, there's not really a medicine that you can take for that. It would be more about focusing on what foods you can eat that have good or healthy fats in them that can increase your good cholesterol. So this is an example of high cholesterol foods that have a lot of LDL or bad cholesterol. It tends to be things that are really high in calories but low in nutritional value, have a lot of saturated fats in them, and the things that you typically would think of as being unhealthy tend to be high in bad cholesterol. Whereas this picture shows some foods that tend to be good for increasing your good cholesterol, like healthy fats like avocados, seeds, nuts, lean meats and proteins, vegetables, whole grains, all of the things that we typically think of as being pretty healthy. Here's some more good cholesterol foods. And dark chocolate is on there as well, which in moderation can be good for you. So if you have high cholesterol, there are a few things you can do. And most of those things are the things that have come up again and again. But even when you're doing a great job of all of these things, you still might find that you have high cholesterol and that you need a medication, and that's really common, and that's okay. And that's because there are a lot of other factors that are beyond our control, like genetics and family history, that play a role here. And so statins are some of the most common medications. And I have a lot of patients who are on statins and a lot of patients who have a lot of questions about their statins. And they're by far the most common class of medications that we use to help lower cholesterol in the blood. And sometimes if you have diabetes, for example, your doctor may suggest that you are on a statin even if your cholesterol is under control, because it can generally help lower inflammation and lower your risk of things like heart attacks and strokes. So below are just some of the most common questions that I get about them. One is, how do they work? And they address your liver directly, because your liver, like I said, is where your body makes cholesterol. And the statins interfere with the liver's ability to make cholesterol. So they help your body make less cholesterol. But they don't really do anything for the cholesterol that you're getting from your diet. It really just works on how much cholesterol your body itself is making. A lot of people want to know when they should take their statin. And if you have a pattern that works for you, then that's totally fine. I generally tell people to take them at night, because without any other medications, because your body makes the most amount of cholesterol at night. And so it can be a little bit more effective if you take it then. But if you take it in the morning and that's part of your routine and that works for you, then that's okay. A lot of people have concerns about the side effects of statins. And the most common one that people hear about is muscle aches. And this can happen. True muscle injury or damage is really, really actually pretty rare with a statin. But if this happens to you with the statin that you're on, you can always ask your doctor about it, and you might consider switching to a different statin, because just because you have this with one statin doesn't mean you'll have it with every statin. There's many different types of statins that are in this group. And then I think another thing a lot of people hear is that if they are on a statin, they can't drink grapefruit juice. And this is true for some statins, but not everyone, because the grapefruit juice interacts with your liver in similar ways and can make the statin a little bit less effective. But you should, if you have concerns about this, I would just ask your doctor, and they can probably tell you if the particular statin that you're on means that you shouldn't be drinking grapefruit juice or some other foods.
And Molly, how about aspirin and its sort of role for heart health, coronary artery disease? I think we talked about aspirin a bit when we did our stroke presentation.
Yeah.
So I was wondering if you could just speak about that a little bit.
Yeah,
too.
that's a great question. So aspirin is like probably one of the most common medications, and so many people are on it. And it used to be that we thought that aspirin was a really good way of preventing heart disease. But newer research has shown that if you've never had any heart disease, you shouldn't necessarily be on aspirin, because it can increase your risk of bleeding, and that tends to be more predominant than whatever benefit it offers in terms of decreasing your risk of heart disease or stroke. But if you've ever had a heart attack or a stroke and haven't had any major bleeding, then in that case, you should be on aspirin for what we would call secondary prevention, meaning you've already had this happen, and in order to prevent it happening again, then it's been shown that aspirin has clear benefit. But I think there's a whole contingency of people who have been on aspirin for primary prevention for years and years and years, and are pretty attached to it and hesitant to come off of it.
Thanks.
And then next is our quiz, if people are up for it.
Yeah, let's do it.
Okay.
And as you're pulling that up, Molly, I would just remind folks to, if you do have questions on either anything that Molly did cover or did not cover, feel free to submit those through the Q&A feature at the bottom of the screen or in the chat. And we'll take just a second to get your quiz pulled up.
Now my computer appears to be completely frozen.
Always happens, right? When it's time to,
Yeah.
when you actually need the technology. Molly, it might also be easier to turn off the screen share for a second, pull
Okay.
it up, and then
See.
resubmit. Folks, John Leantonio is here with us also. I know you probably know John from some past programs. I don't know if you were able to see him before, but Dr. Leantonio from Jefferson and also the Elder Initiative Board.
Nice to see everybody virtually, or not really see you.
Can you see that?
Yep, we can see it.
Yes.
Okay. I don't think we talked about everything in this, so some of it we may just be guessing, but that's okay. Okay, the first question, true or false? Heart disease is the second leading cause of death in the United States. Anyone want to venture a guess?
Again, folks can put these in the chat or in the Q&A if you want to
We'll just give them a second, Molly. See
share your answer.
Okay.
Don't be shy.
John thinks it's false.
I think so too. And we were right. It is not the second leading cause, but the leading cause itself. Okay. How many American adults have at least one of 3 key risk factors for heart disease?
So we're looking at 6%, 12%, 22%, 47%. Anyone want to take a guess? All right, we have 1 vote for 47.
I'm going to go with John's vote.
All right, John, you're leading the way here so far.
John is right again. It's about half of everyone in our country that has at least one of these risk factors, being either high blood pressure, high cholesterol, or smoking. How many heart attacks happen each year to people who've already had a heart attack? About 1/2, about 1/4, or about 1/3?
Any guesses on that?
I don't know the answer to this one.
I'll guess 1/4.
Okay. A good guess.
All right.
So about 1/4 of people who have heart attacks every year have already had a heart attack in their life. So that means that the majority of people who have heart attacks every year have never had a heart attack. And men and women can have different heart attack symptoms. What symptoms are more likely to happen to women than men? Nausea, unexplained tiredness, and jaw pain. That's option 1. Option 2 is arm pain and chest pain. And option 3 is shortness of breath and shoulder pain. John's still in the lead. I think he's right again. Yes, that's exactly right. Blank happens when plaque builds up in the arteries and limits how much blood can get to the heart. I think I only mentioned this very, very briefly, so this is a hard one, but the options are arrhythmia, atherosclerosis, or atrial fibrillation. John again. I was counting on him when he came through. Yeah, that is exactly right. And then the last question, this one seems like a trick. By making healthy choices, you can help lower your risk for heart disease. Which of these is not part of a healthy lifestyle? Lifting weights, drinking 3 servings of alcohol a day, eating a high fiber diet. Thank you, Caitlin and John. Correct. We did great. 100%.
Great job, team.
That is all I have for today.
So I again would encourage folks to get in any questions that you have. One of the ones that I wanted to ask that we try to ask in a lot of these doctors in programs. So what, where would a cardiologist come in? So what is someone talking just to their primary care doctor about, or their geriatrician? And at one point is someone going to a specialist, in this case, like a cardiologist?
That's a great question. I think with your primary care doctor, that's a really good place to talk about preventative things, and you can definitely work on lowering your blood pressure and lowering your cholesterol there, and doing everything that you can do with your primary care doctor to decrease your risk of a heart attack or heart disease. And certainly once you've already had a heart attack and it's clear that you've had like the most extreme effects of heart disease, then it's probably a good idea to have a cardiologist on board as well. And I think even if you know you have coronary artery disease and you haven't yet seen a cardiologist, but you're having symptoms regularly, you're having some chest pain, then your primary care doctor might suggest seeing a cardiologist for some more advanced testing, something like an echocardiogram or a stress test.
So another question that just came in. So where to get information on what to do if you have your first heart attack or a stroke, besides calling 911. And so I guess I would expand on that a little bit of sort of to also say maybe what happens if you do call 911. So if you think you're having a heart attack, what are sort of the steps that are going to happen when you get to the hospital?
Yeah, that's a great question. So if you think you're having a heart attack, you should definitely call 911, and an ambulance will come get you and they'll take you to the nearest hospital. And probably even when you're on your way to the hospital, they'll give you certain medications. They'll give you a really high dose of aspirin. They'll give you something to treat your pain, and they'll probably give you some oxygen, which can just make you a little bit more relaxed and make you feel a little bit better. And then when you get to the hospital, they will get lab work. They will get an EKG. And so they'll be looking at the rhythm of your heart. And in the blood work, they'll be looking to see if there's any evidence of that the heart has died and is leaking certain proteins or enzymes into your bloodstream. And then sometimes it's very clear that you've had a big heart attack. And if that's the case, you would go straight to a procedure where specialized cardiologists would do what's called a catheterization, and they would inject a substance into your arteries to look at the vessels of your heart and to see if there's any specific blockages that they can focus on and open up. That's like the most extreme scenario, and one that doesn't happen as often as the others. The most common is where it looks like you're maybe having a heart attack, but it's not entirely clear. And in that case, they probably will keep you in the hospital. They'll get blood work on you every few hours, repeat EKGs every few hours, and kind of see how things progress. And they'll probably keep you on blood thinning medications during that time. And get an ultrasound of your heart. And then once you've had a heart attack, you'll follow up with a cardiologist, and a lot of people will do something called cardiac rehab, which is kind of like a targeted program focusing on healthy lifestyle modifications and rebuilding your physical strength to get your heart kind of back to where it was before as much as you can.
Folks, feel free to submit other questions. I also wanted to just ask if you could talk a little bit about AFib. I know that came up in one of the wrong answer questions.
Yes,
or answer
sure.
options. But I think that's something that's come up in discussion before. So if you could just talk a little bit about what that is too.
Yeah, so AFib is atrial fibrillation, and it's probably one of the most common abnormal heart rhythms that we see. And normally the heart has 4 chambers, and it has the atria and the ventricles. And if everything goes smoothly, there's like a really systematic and organized way that these electrical signals communicate to each other. And sometimes when there's an abnormal signal, it can just kind of sever the connection between the atria and the ventricles. And that's when you get atrial fibrillation, because the top chambers of the heart are kind of beating on their own and causing this abnormal rhythm, which can either be at a normal rate or it can be really fast. And that's when people tend to get symptomatic and have a lot of chest discomfort and feel like their heart is racing. And when that's the case, if that doesn't stop on its own, that would be a reason to go to the hospital, and you might need some medications through an IV to help slow your heart rate down and to break the cycle of that abnormal rhythm. And for a lot of people who have AFib chronically, they will be on a few medications. One, to make sure that their heart rate doesn't go into that super high range that tends to be really uncomfortable. And also to keep your blood a little bit thinner, because when the heart is beating in that really disorganized way, there's sometimes just blood sitting in the atria. And when the blood isn't moving through the heart as efficiently, that's when you run the risk of it going out of the heart the other direction and going to the brain or the legs and getting a blood clot or a stroke. So that's what the blood thinning medication helps with.
Great, thank you. Did anyone have any other questions before we wrap up for the day? Just making sure we didn't get anything on Facebook either.
David, have you been making any comments about people registering for COVID vaccines?
I don't think we have in Dr. Zinn before, but if you want to take a moment to give any info you have on the subject, please
Yeah,
do.
so I know it's been a kind of a complete mess about this. I know you guys may have some questions, so I figured we could give an opportunity to answer a few questions on that. We are going to be talking more at some future programs about COVID vaccines, but I figured while we're here, as you know, it's been kind of a slow rollout in Philadelphia. The city has a website where you can register and put your name on the list essentially, and then the city will notify you when there is access, and you can actually make a vaccination appointment. The other person to check with would be your primary care doctor. Most practices that I know of in Philadelphia have not gotten shipments of the vaccine yet. At Jefferson specifically, I know we are currently awaiting to be able to give them out to the community. It's been a slow start. I know it's been really frustrating for a lot of people. I know that we are hopeful in the next few weeks that will be coming. I think it may be coming even sooner at your community pharmacies. Last I heard, CVS and Walgreens is getting a huge batch of this to make this easier for folks to get. So I certainly say stay tuned. Pay attention. There are daily briefings from the city with information about that. And I think that that's a pretty good resource for information. And I see David put the link in the chat box. If anybody has specific questions about the COVID vaccine and what we know so far, we're happy to take those now too. Give you a chance to.
Great, thanks, John.
Yeah, of course. I know it's on everybody's minds.
And I think, and we can try to, in future months with Dr. Zinn, continue to provide the updates on that.
Cool.
As more information becomes available. We also try to share stuff for those of you who follow the Elder Initiative, do try to share stuff on our website, on our social media to continue to get the information out there as much as we can, because obviously there's it hasn't been a perfect rollout. I think folks would agree. Well, thank you so much to everyone who joined us today. Thank you, Molly, for the wonderful presentation on heart health. I think there's a lot of great content that hopefully folks can take and look at ways of reducing their risk for cardiovascular disease and keeping hearts healthy. Just an announcement about our next program. Tuesday, March 9th, we are talking about exercise, something that came up today as one of the important things for folks to be doing. So that might be a little bit harder to do now than in years past, given some of the current constraints on where we can go, what we can do. But hopefully you all will join us next month as we talk about that important topic. And we will leave it at that. Hope everyone stays well, stay safe, and we will talk to you all soon.